My name is Khalid Abdel Karim. I'm professor of clinical oncology at Ain Shams University, Cairo, Egypt. I'm a pride neuro-oncologist of Ain Shams. We have been for like 10 years the only neuro-oncology department in the oncological centers in Egypt. I was very much proud to host the first ESTRO course, Falcon course in Cairo some 5 years ago. And today on continuum of our education and collaboration with the ESTRO, I'm very much proud to introduce Dr. Raj Jaina. He's a consultant at University of Cambridge of neuro-oncology. He has an impressive publication on mostly neuro-oncology and other, not only oncology, but a lot of theoretical and physical studies, imaging studies. I was so much impressed when I was reviewing your resume, sir. So without any due delay, so I will introduce him to start with the cranial SRS key principles of clinical use. The floor is all yours, sir. Thank you.
Thanks, Professor, for the very warm introduction. So my name's Raj. I'm half academic and half clinician. And as Professor said, my academic work is mainly in neuro-oncology and radiosurgery, and my clinical work and my academic work is in image processing and artificial intelligence. So I guess my aim this morning is to try and convince more of you to become neuro-oncologists too, and to excite you and enthuse you in the topic. So we have a series of lectures to go through this morning, and we'll just begin basically with some principles, just to think about the decision-making and our thoughts behind undertaking radiosurgery treatment. Okay, so just briefly over the next half hour or so, I'd like to cover some thinking about the radiobiology of radiosurgery and some things why we think differently about tumor response when dealing with radiosurgery compared to conventionally fractionated radiotherapy. I'm based within the UK National Health Service, so I will discuss a little bit about the commissioning protocol that we apply for using radiosurgery treatment, mainly for metastases, and look at some metrics of efficacy. Then really to focus in on the clinical practice of stereotactic radiosurgery, some of the thoughts that we make, and then to think about extending this technology towards thinking about the boosting of tumor cavities after patients have undergone metastasectomy and the management of radionecrosis and leptomeningeal disease. And then linking in with that, the idea of maybe it'd be a good idea to give radiosurgery before surgery in order to reduce the toxicity. And then just to check that you're listening to me, a couple of case histories that we'll just go through briefly. Okay, so this is an old paper from Zvi Fuchs, but it's a good paper. And I think what I encourage you to think about is that the biological response to single high doses of radiation therapy is different. When we give more than 10 gray of radiation into tissues, the response changes from our normal thinking of single strand and double strand DNA repair. If you were in the physics session yesterday, you heard a little bit about the LQ model. But I think in our case, we think that radiosurgery is targeting the vascular component of the tumor, so that when we have this normal mechanism of tumor cell damage and mitotic cell death or apoptosis in conventionally fractionated radiotherapy as the main mechanism, and damage to blood vessels as the secondary mechanism, when we're giving large doses per fraction, I think it's the other way around. And that mainly what we're doing basically is to cause death of endothelial cells, and that leads effectively to microvascular dysfunction. And we know this because actually you can study this in vitro and in vivo mouse models. You can create knockout mice where this pathway that involves ceramide as the main signaling mechanism actually abrogates the response to radiosurgery treatment. But it's a difficult model to study because the animals get other neurological problems that leads to early death. The other thing I think that we're increasingly thinking about is how we combine immunotherapy and ionizing radiation. And again, you can see in this cartoon that there are interesting reasons why radiosurgery in particular might be a good candidate for combining with immunotherapy. This idea of an abscopal effect, that you have effects on activating the immune system at some distance from where the radiation dose goes. So the first thing that happens is that we see more tumor antigens being expressed as a result of radiosurgery. In particular, the presence of DNA fragments outside the nucleus is a very strong stimulus, and that's recognized by a range of pathways, the main one being C-gas sting that leads to the production of type 1 interferon. And again, if you were listening to some of the talks yesterday, this was discussed. There are other mechanisms that occur as well, and that cells, when they've been irradiated to high dose, start to express different receptors on the surface. And they start, in particular, calretinin is one of the surface markers that's expressed. And it also results in a loss of PD-L1 expression, which is often used to cause anergy of the immune system so that tumor cells can hide from the effect of the immune system. So all of these things are consistent with the idea that we can use radiation therapy, in particular high single dose radiation therapy, as an immune adjuvant to activate the immune system to the tumor where it may have been hidden. So yes, so I just discussed that, what we said. So we also have to consider the volume effect of radiation treatment, because we want to generate these abscopal effects from the tissue of the tumor. But there may be some theoretical thinking that the dose to lymphoid tissues, those antigen-presenting cells that are going to recognize these new tumor antigens, may be sensitive to radiation. And the idea is to achieve a balance between the radiation actually causing tumor damage and activation of the immune system, but not too much effect in the local lymph nodes so as to cause weakening of the immune system. So again, this is another argument why highly conformal radiotherapy treatments, probably more the case in the body than in the brain for SABR treatment, might be particularly useful. So again, thinking about where things are different, we often think about our ICRU concepts of CTV and PTV margins. And in radiosurgery, we're tending to not use the same thinking. It is not common to use a CTV margin at all for stereotactic radiosurgery. Your imaging should be clear enough that you can define the edge of the margin. And if you use, as we do in Cambridge, a linear accelerator to deliver radiosurgery treatment, we have this bad habit of applying a PTV margin. I guess we're just so uncomfortable with the idea of not applying a PTV because we may have some uncertainty residual in the positioning of our tumor after all of our localization. But of course, in gamma knife systems, where the thinking, I guess, is more mature, it has become more prevalent not to use a PTV margin. And I think that is the right concept, effectively. Because the PTV margin really applies to the thinking for conventionally fractionated radiotherapy, where you need to cover all of the tumor-bearing volume, anything that may have some clonogens in it, and give enough dose to bring the number of clonogens down to 0 in every single location. But with radiosurgery, that's probably not how it's actually working. You're probably causing enough damage to blood vessels and activating the immune system. And so the PTV margin is just increasing the risk associated with the radiosurgery treatment. So we can see here some published data that shows that when it comes to local control, there isn't actually an advantage to adding a PTV, and certainly no advantage to adding a PTV that's greater than 1 millimeter in size. But the cost is high. We see a higher risk of pseudoprogression and brain necrosis when we use a PTV margin with particularly linear accelerator-based radiosurgery. So we have to think, well, how are we going to achieve this? And we know that what we're using effectively is multiple beams or multiple arcs that are very tightly focused in order to actually conform our dose into our target. The difficulty that we face with the linear accelerator compared to an instrument like the Gamma Knife, which is custom designed for delivering radiosurgery, is that as we try to increase the modulation, how much we change the shape or the size of the beam, that increases how long it takes to deliver the treatment. And of course, movement during the treatment is your enemy. It's the thing that you can't control during radiosurgery. So again, if we're going to use linear accelerator-based techniques, you have to think carefully, how can I get the treatment in as quickly but as precisely as possible? And in many settings, it may just be sensible to use a conformal arc, simply because the delivery can be done in seconds rather than in minutes. So this might be interesting to you to see basically how we think about choosing patients, particularly for metastasis radiosurgery in NHS England. We are constrained by national guidance so that all of our patients have to fulfill all of the rules that you see here. And essentially what we're looking for is fit patients, KPS greater than 70. We have to make sure they haven't had radiosurgery at least 3 months interval. We can only give radiosurgery in the UK at 3 monthly intervals. And they should be expected to survive at least 6 months if you can control their intracranial disease. It's very important also that we have contemporary information about their MR imaging and their staging scans. And in the UK, we can treat any number of lesions, but there's a maximum volume of 20 cc's of GTV that we're actually allowed to treat. And that, once we have all of that information, then we're able to go ahead and deliver the treatment. And we're mandated to deliver that treatment within at least 14 days from decision to treat. For the other indications, skull-base meningioma pituitary, we have a little bit more time and a little bit more flexibility. And in the UK, vascular indications, and in particular radiosurgery in children, is consolidated to the larger centers where they have both a Gamma Knife and a linear accelerator and more expertise in treating that particular group of patients, which I think is the right approach. Patients can have the majority of radiosurgery within an hour from their home, but more specialized treatment involves more travel. So what do we do? So for lesions that are less than 1 cc in size, for these particular tumor types, where we get a good outcome, we deliver 24 gray in 1 fraction to the 80% max point isodose. For lesions up to 7 cc's, 21 gray, and then 13 cc's or more, we're fractionating in 3 fractions. We rarely deliver brainstem radiosurgery, but if we do, we use 30 gray in 6 fractions. And notice we prescribe to a higher max point isodose. And the reason for that is that it means we get a more uniform dose within the brainstem itself. We worry a little bit with the brainstem being such a sensitive structure to have very steep dose gradients within it. And our local protocol for the skull-based tumors, again, fairly standard. 12 gray is our standard dose for vestibular schwannoma, and for meningiomas, depending on the grade and location, between 12 and 14 gray, again, to the 80% max point isodose as per LINAC-based radiosurgery. So, of course, it means nothing to say 12 gray to the 80% isodose without understanding what's actually happening to the plan underneath. And I think it's worth just thinking about some plan metrics for those of you that are not familiar with thinking about radiosurgery plan evaluation every day. So the concepts that we need to consider are we're always trading between coverage and conformity. So coverage is easy to understand. It's the proportion of the target volume that's been covered by your prescription isodose. Oh dear, what happened? Okay. And then selectivity is effectively the prescription isodose volume that you prescribe to that covers your PTV divided by the volume of the PTV itself, so that you start to get the idea that a plan can cover the entire lesion, but you want it to actually be more selective. You want it to shape around the shape of your target. In particular, if the target is not spherical in nature, the selectivity index is very important. And then to express this trade-off between coverage and selectivity, we multiply the two. And we end up with the Paddock Conformity Index, named after Ian Paddock, who's one of our radiosurgery physicists in the UK. It's always going to be less than 1 when calculated this way, and higher is better. So you want to have Paddock Conformity Index of greater than 0.5. And a little trick that you can remember is that if you have covered the lesion completely, then coverage is 1. The Paddock Index is simply your selectivity. Okay, so the Paddock Index tells you something about the compromise between covering the target and how closely you've shaped the target. Then you need to understand the consequence to the surrounding tissues for doing so. And this is expressed as the gradient index. So the gradient index effectively tells you how quickly dose falls off into the surrounding healthy tissues for a given choice of coverage and selectivity. And the gradient index is calculated by taking the volume of your prescription isodose and then taking the volume of 50% of the prescription isodose as well, so that you can see basically what you want is that the 50% isodose will be as tight as possible around the 100% isodose, so very steep dose gradients. Then the final thing to think about is the overall volume of brain that you're treating, subtracting your PTV. If you've used a PTV margin, we tend to be more conservative and take the volume of brain receiving more than 12 gray minus the GTV. And again, this should be less than 10 cc's for single metastases in order to reduce the risk of radionecrosis. Okay, so I've just discussed what's shown on this slide. Sometimes if we're doing multiple metastases, we can't allow for a volume of brain that's receiving less than 12 gray to be as small as 10 cc's. And what we have to consider is that you might be treating multiple metastases, but effectively they're all within different volumes from each other, so that the risk of the different lesions interplaying and causing increased dose to the same part of normal brain tissue can drop. So we can use a slightly higher threshold if we're treating multiple metastases, and again, higher threshold if you're using fractionated radiotherapy. So if we think conservatively in terms of the benefit for metastases, for the longest time across the gamma knife and linear accelerator era, we knew that the best outcomes in terms of overall survival were for those patients with 1 lesion. We then have level 1 evidence to show that there's neurological progression-free survival for patients with 2 to 4 lesions. And again, this is going from very old data. This is grouping all of the patients together without taking any other factors into account. And then very importantly, Dr. Yamamoto's paper from the Japanese Gamma Knife Consortium actually showed that that limit was set too low, and that across all of the lung cancer patients that they treated with Gamma Knife, a huge data set collected from all of the Japanese centers, actually you could see that there was the same survival benefit regardless of whether the patient had less than 4 lesions or less than 2 lesions. I think the thing is, this data is useful. It's the data that we have, but it is largely before the era where we had such good targeted therapies to follow after radiosurgery in the brain. We heard, for example, about the effect of dual HER2 blockade in breast cancer yesterday, and patients are going on to have an expected survival 18, 24 months now, sometimes with systemic treatments. And then we have some of the tyrosine kinase inhibitors, particularly in EGFR lung cancer, showing very, very long survival over periods of time. So I think for LINAC-based radiosurgery, we normally say that the benchmark is to achieve a 92% local control rate at 12 months, 84% at 24 months. And we should aim for a confirmed risk of radionecrosis of around about 7%. That's normally what we discuss with our patients. Okay, so just moving to thinking about the fact that we use combinations of radiation and surgery together, and what is the best way to do this? This causes us great concern back home, because we have a linked practice where patients are referred into a structure where both the surgeons and the oncologists sit, and both treatment options are offered in parallel, rather than the patient being referred directly to the surgeon. and the surgeon deciding which is going to be the treatment. So we know over, again, many eras of data that there is benefit to giving radiotherapy after a patient has a metastasectomy. But the evidence for what it should be, if you look over the longest era, again, the strongest is for whole brain radiotherapy, and no one likes giving whole brain radiotherapy. I don't know if that's the same in your practice, but certainly in the UK, no oncologist wants to give their patient whole brain radiotherapy if it can be avoided. Equally, our neurosurgeons really do not like reoperating when patients have had local recurrence of their disease. And we've seen local recurrence rates in UK practice for different centers being as high as 30 to 40% where radiation is not given. There is also this intriguing idea that the surgeon opens the surface of the brain, the dura, in order to access the metastasis, and that on the way out, tumor may be seeded onto the surface of the brain, causing an increased risk of leptomeningeal recurrence. And if you look for it in surgical series, you see that this incidence of leptomeningeal spread after surgery is between 4% and 12%. And it seems to be much higher if the surgeon has had to remove the tumor in sections rather than remove the whole thing, when compared to, for example, using just radiosurgery on its own. So radiosurgery leaves the dura clean, and that is a benefit potentially, although of course there are other trade-offs. So we're often asked to give a cavity boost after surgery. And the problem is, if you think about it, this is easier in theory than in practice. Because let's say that you have a patient, they have a 2-centimeter metastasis, and you're going to treat with radiosurgery. You know exactly what the target is. You know exactly the shape. You can define your conformity measures and the like. But if the tumor has been removed by the surgeon, the cavity will be much bigger than 2 centimeters. Often it's bigger than 3, 4, 5 centimeters. And what you're trying to target with radiosurgery, by definition, is mainly normal brain. You're trying to target a hole where the tumor used to be. So this means there's a much higher risk of radionecrosis, which makes sense. You're treating a larger area, and you're treating normal brain as well. So up to 24% in some studies. So in some centers, and again, this is what we tend to do, we reserve it for when the surgeon tells us this was a problematic excision. The tumor came out piecemeal. There's an MRI scan that suggests there may be residual disease. And there's a slightly different balance, basically, of risk and benefit. So what does this do in terms of the actual patient outcome? Well, sadly, there's no difference in overall survival, whether you give SRS when the patient recurs in the cavity or you give adjuvant radiosurgery, which means that treatment at recurrence doesn't compromise the local control of the disease. And sadly, this is what defines our current practice in the UK. But I think it is difficult because obviously recurrence of disease is morbid for the patient. And you have to think, well, what am I going to do now compared to trying to give the treatment up front? And so what you can see effectively is that across a series of studies, you compare cavity boost to whole brain radiotherapy, and you can see always about the same pattern, that the survival is about the same. Patients do better overall with focused radiotherapy than whole brain radiotherapy. Anita Mahajan's study, which is another interesting study, looking at either giving radiosurgery or just observing the patients and treating when they relapsed. Again, you can see that there's a much lower freedom from local recurrence at 1 year if you just watch the patients rather than giving radiosurgery. And this is telling us that many of these patients in this unselected series, they need something after surgery. But what it is, we have to think what it is, what it should be. So we have this idea of neoadjuvant radiosurgery. So it's very attractive in some ways. First of all, we have the target in situ, so we don't have to treat with a margin, and we can treat a much smaller volume. So there's a lower risk of radionecrosis. There's also this idea that we could reduce the risk of leptomeningeal disease by sterilizing the tumor partially before the surgeon operates, so that there's less risk of viable tumor cells being left on the way out. And the studies show that typically you can give 20% lower doses, perhaps even lower than that, and still maintain this efficacy if you give the radiosurgery first, because the surgeon will debulk the actual tumor. And again, we can see that it's well tolerated. As long as you do the radiosurgery within 10 days of an operation, there's no excess morbidity. It doesn't make the surgery more difficult. And there's the fantastic thing, is to see very, very low rates of leptomeningeal disease and no risk of radionecrosis effectively. So the studies have been done that basically try to compare either giving radiosurgery preoperatively or post-operative whole brain radiotherapy, because that's the treatment for which we have evidence. These are retrospective analyses, of course, because it would be difficult to do a study like this prospectively in this current era. And it included some larger lesions than we might normally consider for neoadjuvant radiosurgery treatment. But broadly, what you can see is that the survival curves are very close. And again, preoperative SRS, the tail of the survival curve is better than giving post-operative whole brain radiotherapy treatment. So again, if we compare with historical figures for leptomeningeal disease, we can see that there is slightly higher risk associated with post-operative radiotherapy than whole brain radiotherapy. It makes sense. You're sterilizing the entire surface of the brain when you give whole brain radiotherapy. But with neoadjuvant radiosurgery, you see very similar rates of leptomeningeal disease between the neoadjuvant and the whole brain radiotherapy. So as the doses are now being pushed in the latest series, they're starting to see radionecrosis. Why? Because the surgeons like this technique, and they're asking for the neoadjuvant radiosurgery to be given on larger lesions. So now they're continuing to do that, but at lower dose, and they're fractionating the treatment basically when they're treating these larger lesions. Okay, so just to check that you were listening, just a couple of little case histories just to go by. So this is a patient who's 72, metastatic bowel cancer diagnosed 2 years ago, who has stable liver metastases, and he's been off systemic therapy for 6 months. He presents with a seizure and a headache, and his Karnofsky score is around about 75%. When he's admitted, you can see this is the imaging. You can see that he's got an enhancing lesion in the frontal lobe, and you can also see the significant edema associated with this lesion. So who would treat this with radiosurgery? No one. Oh, Professor Wood. Okay, a few people. Who would offer surgery first in such a lesion? I'm going to put my hand up, maybe. I think, yeah.
Not compressive and affecting the general condition. To do a safe decompression, then radiosurgery is the answer for the neurosurgeon who were always thinking about us as the enemies. So they are now thinking a safe debulking only if it is symptomatic and severely affecting the patient for fear of more edema to happen.
Exactly right. So that's the exact thinking, is this patient has come in, they are symptomatic, okay? The headaches and the seizures, I haven't told you, they're proving difficult. They're not responded completely to corticosteroids. So in this situation, when we discussed it, we felt that we would allow the surgeons to go first in this situation. And do think if you've got significant mass effects, then surgical debulking is going to get you out of trouble more quickly. Okay, so the next case is a patient, so this is one of my patients, this really happened. So EGFR wild type lung cancer. He had a very good response to primary immunotherapy. He had to stop because he got very bad lung disease and then switched to primary chemotherapy treatments. And basically, at one point, they were just restaging him and they scanned his head with an MR, but he was asymptomatic. And you can see that there is this very small 5mm lesion that's visible in his brainstem. So what treatment would you recommend? Who's going to recommend surgery now? Great. I don't want to see any hands going up at all. Okay. So there's no role, obviously, for surgery here. But this is a situation where I thought I might be able to use the brainstem radiosurgery protocol safely because the patient's quite fit, not too much symptoms, and a fairly small target. Now, what I didn't know was that the patient, when I saw him, was still receiving the chemotherapy treatments. It hadn't been stopped because this lesion had been detected incidentally as part of the staging workup. They wanted to refer him into a new clinical trial that required an MRI brain. So on his planning scan, this is what I saw. I don't know if you can see that very well, but effectively that enhancement has gone. There's a very small cystic area still visible in the brainstem. So who would, with this scan, so I'm now sitting here on the radiosurgery system, ready to draw my target volumes. Who would treat this lesion? Abdel has more experience than me. So that's interesting. I didn't treat this lesion because I thought it would be interesting to see how much more response we would get from systemic treatment. In fact, indeed. No, so I had the discussion with the patient when I had the planning scan, and the patient themselves, they were not keen on having the radiosurgery treatments. So what actually happened was we continued to monitor the patients. I did in the end have to give further radiosurgery treatment to this and some other metastases. I think approximately 9 months later, he had 3 monthly MRI scans. And then when we saw more disease and we thought, let's treat everything, we treated everything together. Okay, case 3. So this is a patient who has a BRAF mutated melanoma. He has slow progression of liver metastases, and he's starting a tyrosine kinase inhibitor. Again, the screening MRI was done for this situation. And again, on this scan, you can see multiple lesions. They're all fairly small volume, visible within the brain. So what would you do in this situation? Who'd offer radiosurgery now? It's difficult, isn't it? Yeah. What we actually did was, because of the multiplicity of the lesions, and because he was just starting the tyrosine kinase inhibitor, we watched to see whether any response was seen. The patient actually had quite a good response for about 14 months, not unusual for a tyrosine kinase inhibitor. And then, in fact, he had what's called oligoprogression. So interestingly, the only lesion to progress on the tyrosine kinase inhibitor was this one, the biggest one. So we ended up just giving radiosurgery to that. I haven't heard back from the patient since, so we will see what happens, basically. Okay. So this is a 56-year-old lady with a newly diagnosed operable lung cancer who then had a seizure and presented with a synchronous brain metastasis. And you can see this is quite a large lesion that's sitting here, okay? And just for reference here, this is the central sulcus on the other side. So we can see effectively that we'd expect this to be adjacent to the motor cortex. So in the discussion here, who would ask the surgeons about operating on this patient? You can ask, but they say no, because the risk of hemiparesis is too high, effectively. So again, this is a situation where you would give fractionated radiosurgery. So SRT 25.5 in 3 fractions was what we chose to give. Actually, the patient did very well. So I think overall, when you think about it, we can see, we've talked a little bit. I give my talk and it's based on linear accelerator-based radiosurgery. Other centers have much more experience with the gamma knife system. And I think once you are familiar with your treatment technology, you understand how to drive it, and you're familiar with how to assess plans, then actually the pathway of getting the right patients in for radiosurgery and how you choose the patients is much more important than the actual treatment technology that's used for radiosurgery. And I think, oh, I should have taken that off. So this is one of my colleagues who's basically trying to set up a study in the UK as a randomized study between neoadjuvant radiosurgery, post-operative fractionated radiosurgery, or observation. And this is proving to be a difficult thing to do because people have ideas about what they really want to do. So there's a loss of equipoise, which is very important when trying to set up a randomized clinical trials. Okay, so I'll stop there. If there's any questions, I'm happy to answer them.
Is a little bit interactive. From my point of view, as a one who struggled to say there is something called radiosurgery for the brain from 2000. We started our first Gamma Knife in Cairo, 2000, and everyone would say whole cranial radiotherapy is preventing further metastasis. This proved to be wrong. This proved to be decreasing the overall survival, not improving it, decreasing the disease-free survival. So it came clearly from your presentation. Just a remark. Again, I needed to know your concept about using the new imaging technologies instead of going for surgery just to prove the tissue and the markers, because many of the imaging process like the MR spectroscopy, the perfusion, the diffusion are going even to give us some element about the response to chemotherapy right now, because they are going vast beyond what we know some 10 years ago. If you would comment on that, please.
No, I think that's a very good point. You know, when we look at diagnostic accuracy now for spectroscopy-based MRI for tumor versus non-tumor indications, particularly with multiparametric MRI, you know, in expert hands, then the AUC curve is reaching something like 0.8, which is excellent, really. I think the problem is that our systemic therapy colleagues, they're asking a different question of the surgeons now sometimes. And what we find is, particularly if the patient presents and have brain metastases and we can't see an obvious primary, they're wanting the other molecular pathology to guide and target the other treatment. So they want to know the PDL expression status to make a decision about immunotherapy. They want to know the EGFR status and which mutation actually is driving this particular case. So I think it's interesting what we're actually seeing, what we're being asked for by our oncology colleagues. And so I think, I'm sure that is correct. I'm sure that we can make many more radiological diagnoses. I think it's whether we can keep up to speed with the increasing sophistication of molecular pathology. That will be really interesting to see. So, yeah.
Any questions from the floor?
Thank you for your presentation. My question about BTV margin when we are using a CyberKnife machine, either in single or fractionated radio stereotactic.
So I didn't quite
BTV margin in CyberKnife machine.
Yes. The margin you're asking about?
Yes.
Yeah, again, I think most CyberKnife centers do not use a margin because they come from the same line of thinking effectively. Even though a CyberKnife is Linac based, the collimation and the systems that are used, often also many of the centers in the UK at least that had Gamma Knife for many years, they paired it or replaced with a CyberKnife. So it seems to be that's the thinking that's applied.
And just a little
me, I would love to drop the PTV in my department.
Even in fractionated 3 or 5.
The fractionation is not changing the concept of SRS. The concept of SRS in the brain, especially when you are dealing with benign tumors like meningiomas per se, there is no way to think that accurate treatment, that rapid fall off, and that what we call like the fractionation is not the matter. What you are dealing with, what is the tumor, you are not dealing with what beyond what you are seeing in the tumor. We are not this is not a moving organ in the brain like you are treating what is in the lung.
Fractionated
Again, it's not the matter of fractionation. It's the matter of choosing the target for SRS, because the fractionation, you are fractionating to prevent the dose from harming the normal brain. But when you are that sharp, that delineated, the matter is not the fractionation.
Absolutely.
Because we are having the fractionation to deal with larger tumor. We are having the fractionation to deal with many lesions. It is not the fractionation to preserve the normal brain. So we should be that sharp and that delineated.
Yeah.
Sorry, sir. Thank you.
Indeed. And if you use fractionated protocol and your dose per fraction drops below, you notice we use 8.5 gray per fraction as the minimum fraction size, because what you mustn't do is to drop dose per fraction so that you do not cause the same biological effect. And then that way, you know, it is still radiosurgery by intention, we hope by biology, but just made a little bit more safe.
Thank you.
Please. The mic.
Hello, is there a maximum volume for brainstem metastasis, like the CCs? The brainstem metastasis, is there a maximum volume to be treated, or you can treat any size?
Again, actually, we've treated very few. So I haven't treated a lesion larger than 1 cc for brainstem SRS, but actually my experience is rather limited.
No.
Prof is probably able.
Again, it's the matter of proportion. When we are doing the MDT with the neurosurgeon and with the imaging expert, we are dealing with what's left. If you are, I'm using the words of Ian Paddock and Dr. Landquist when I was in Cromwell some 20 years ago. They were the mentors then. You are burning the damn devil. They used that word. So anything. So if you are going to treat a lesion that would burn most of the volume, think volumetric, not two-dimension, the most of the volume, and will cause later on severe edema, don't. It's not the answer. So the professor is saying it's 1 centimeter. Sometimes you can go a little bit with decreasing the overall dose, not up to the 20 or the 24, you drop to 18 or 16 even. But less than that, you are losing the efficiency of the SRS. Larger volumes, you are harming the normal brain. So the answer will be not SRS. Thank you, sir.
Great, fantastic. So one of the things about being a neurosurgeon, a neuro-oncologist, is to hug the anatomy of the brain, which I always loved. It's the reason that I did it. So the next topic is just to think about some anatomy concepts that are relevant for radiosurgery treatment. So just very quickly, not to go through all of the skull base anatomy, because that was painful at medical school when you did it the first time, and it would be painful to do the whole thing today. But just to think about specific things that we come up when thinking about radiosurgery, the cranial nerves and how they appear on MRI, and also thinking a little bit about dural and vascular enhancement when we're defining target volumes, because this is something, until you actually try and do it, you think, what do I do in this situation? It's can be challenging. So just to share some thoughts. Okay, so we all knew this and learned this from medical school. We all had the skull in our rooms when we were learning anatomy as well. And I think that the point to remember when we're thinking about the cranial nerves across the whole of neuro-oncology is to understand their paths, to understand their exit from the brain, and to understand that as each one travels through the foramen, it takes a dural surface with it, okay? And that's really important, because when you see patients with leptomeningeal disease, that space basically between the hole where the cranial nerve exits, which is tight, and the dural reflection that it takes with it, for some reason, cancer cells like to go there, right? And that is why patients will present with multiple cranial nerve palsies. Most commonly, it will be the 6th nerve, because if you remember, the 6th nerve has a long intracranial path. And it's important to think about those things and remember, particularly when giving palliation to the skull base, to remember that skull base anatomy. But it's too early in the morning. I'm not going to tease you anymore with all of that. So I'm just going to focus effectively on the facial, the trigeminal, and the hypoglossal nerves, because these are things that come up effectively when we're actually trying to plan the radiosurgery treatment. These are things that you have to segment effectively if you've got an appropriate target. Whoops. So the trigeminal nerve, that's the easiest one to spot, okay? It's the largest cranial nerve origin, and you can see basically if you have any kind of T2 weighted or stir sequence, it shows particularly the contrast between the cranial nerves and the surrounding cerebrospinal fluid very, very clearly, okay? And so it's outlined by the cerebrospinal fluid and as it emerges from the anterior surface of the pons. And the important thing is that it's close to the level of the internal auditory meatus, okay? So when you look on the CT scan, you can clearly see the internal auditory meatus from the bone, and you can be looking in that region. Of course, that's important because often our target for radiosurgery is sitting in the internal auditory meatus when we're talking about vestibular schwannomas, one of the commonest non-metastasis indications for radiosurgery treatment. So very important to be able to kind of localize that nerve and to be able to segment at least its origin as it sits in this space in the cerebellopontine angle, okay? The trigeminal nerve is a little bit more difficult to see on standard imaging, but basically it relies on you being able to observe Meckel's cave, which you would typically see just anterior to the origin of the nerve. And you can see the origin of the mandibular division is starting from Meckel's cave region. So again, it's helpful to be able to orient yourself and find those structures when you're actually doing your segmentation. So the facial nerve is quite challenging to actually see. And what I find is the easiest thing to do is to find this, the stylomastoid foramen, and you find that on the CT scan, okay? Just remember as a principle, when you're contouring, that you have the CT to give you bony anatomy very clearly, and the MR for soft tissue. So use both, make use of both of those structures effectively. And then what you can then see basically is from the stylomastoid foramen, you can see the nerve and trace it back here to the surface of the pons as it's running through in this direction, okay? And that's important if you're asked to give radiosurgery to any of the lower cranial nerve schwannomas, then being able to identify the facial nerve, it may even be the target in some patients. Me in front of you, those are the key areas basically where you're going to try, where it will be important from a contouring point of view for you to be able to identify the nerve and be able to segment it. And again, it's always useful. You should have ideally your neuroradiologist sitting with you if possible when you're actually doing this kind of segmentation. For metastasis work, that's less critical. But for this type of segmentation, it's always good to have a neuroradiologist actually sitting with you. So if you think about these lesions, when we see lesions that have tumor that is adjacent to or involving the dural surface, I think it's always very difficult to know what to do with radiosurgery, because what you find, I'm sorry if it's not projecting very well, is that you see this is a case of a patient that has two areas of meningioma. The tumor was resected from here, okay, and the patient had been observed for many years, and these two areas of residual disease started to grow and grow, and eventually the surgeon said, I think it's probably time to consider some radiosurgery treatment for it. And the difficulty here is that if you think about your normal radiotherapy segmentation, with fractionated radiotherapy, there would be very little cost to covering the surface of this cavity and this slight dural enhancement, okay? Because if you're giving treatment over 6 weeks, the additional toxicity of treating all of that dural surface, minimal really, and that's probably what you would do if that were the indication. But in radiosurgery treatment, you absolutely cannot do that, okay? That you can't just simply continue and involve a dural surface, and you have to think very carefully what you're doing. Because what happens is that you end up with a highly eccentric shape. Many of the targets that we're aiming for radiosurgery, they grow from a single point. A tumor has a nidus of growth and tends to grow spherically unless constrained by something else in many cases. So what happens is that this unusual shape means that you're going to have a very difficult situation to deliver selective treatment. You might be able to find that your physicist gives you good coverage for the radiosurgery, but it would be at the cost of very poor selectivity. And so what you'll end up doing basically is dramatically increasing the risk of brain necrosis in this area. So this is one of those situations where you have to think very carefully and think, okay, well, this is what I believe to be the important area of contiguous dural involvement. So this is what I'm going to segment. We need to give enough target basically to cover the bulk of that disease. And the aim is effectively is to try and destroy its vasculature and induce a response in that way. That's the key thing. And if it's more than that, and if you discuss with your radiologist and they agree, I'm quite worried about this very extensive dural surface, then it may be safer to actually give fractionated radiotherapy treatment instead. Yeah.
Term by the radiologist and by the neurosurgeon, what they call meningomatosis, yes, which is a vast surface of involved meningioma or involved dura with the lesion, whatever its metastasis or it's genuine atypical meningioma. And as you say, sir, it's not reachable by the limits of the SRS, and it's going for the fractionated much safer. If we are speaking the same language.
Yes,
thank you.
Indeed, yes.
Yes.
And I think this meningiomatosis, a very extensive dural involvement, is a very difficult problem to deal with. But I think here what we can do is we can use, when we're thinking about reirradiating, there are scenarios where we can use fractionated radiotherapy, and then it can be followed by radiosurgery when you have this particular issue. So fractionated radiotherapy may be given to cover a large extent of the surface of the brain that's at risk, and then you may be able to give radiosurgery afterwards if you've got small areas that have continued to grow and the rest has been controlled. Then the other problem, again, I remember when some of our trainees started to have a go at contouring radiosurgery, is this type of scenario. So you have the GTV target, this is a metastasis in this case, and you can very clearly see that there is a feeding vessel that comes into the tumor itself. It makes sense, doesn't it? The tumor will induce a blood supply and it causes hypertrophy of the associated vessel in order to ensure that it has the blood that it needs. Okay, so I had a very interesting discussion with one of the registrars, and she said, well, I want to put it in. I want to put it in my target volume. And I said, why? And she said, well, because Dr. Jenner, you told me that with radiosurgery, you're wanting to target the blood supply. So this is the blood supply. So why not put it in? I had to laugh because I thought, well, she's got me there. She is in one way interpreting what I had said absolutely correctly. But of course, the key point here is that the blood supply that we're looking to disrupt is the microvasculature within the tumor body itself, okay? We're not intending to sort of use radiosurgery as a sort of embolization technique to occlude this vessel, because A, it's not as effective as other non-invasive embolization techniques, and secondly, the dose that you would need to give would be much, much higher in order to actually do that. So again, think about the cost when you're segmenting for radiosurgery and think, if I were to include this structure, then what would happen to my target volume? What would happen to its shape? What would happen to selectivity? And what would happen to the risk of toxicity for trying to offer this treatment? And then you would sort of think, okay, yeah, no, I have to rethink my, what I'm trying to, my strategy here. And I think what's one of the really nice things is that if you use a radiosurgery dedicated planning system for contouring, then you should always try and contour in a native three-dimensional display. Because what would happen is, I've just captured one image here. You can see these blood vessels snaking and moving in and out of the view on an axial image. And then when you look to the other orthogonal views, it's often much easier for you to be able to discern, now this is the feeding blood vessel as it comes into the tumor versus this being the tumor mass itself. So again, I would argue you must use a native 3D segmentation tool if you're actually doing radiosurgery segmentation. Okay, so that's the end of that talk. Just a very brief kind of look through on anatomy. I have here just, you can see basically just an external tool, web-based tool. And so we can try and identify some of these structures. Oh, that's no fun. Let's turn that off. So, okay. Okay. So here we can see there is the trigeminal nerve, and you can see how beautifully it's outlined basically. And there you can see that's Meckel's cave, just as it's heading into the medial surface of Meckel's cave. Let's see what else we can see. So here we can see the outline of the nerve as it goes into the internal auditory meatus. Here we can see the cochlea, some of the anatomy of the cochlea. And then let's just try and see if we can find, let's go down to the foramen magnum. Down here. Now let's come up slowly. Okay. And so here we can see that's the stylomastoid foramen as it's forming. So we just need to follow that. So yeah, it's much easier to do when you have the three-dimensional display, basically, in order to look at that. But again, I think, in this situation, if you're not clear, it's much better to sit with your neuroradiologist and actually go through the imaging directly with them. So, okay. So that's that session. Any questions about the anatomy side of things or any of the concepts that I raised then?
For the collaborative action in any brain unit, we are dealing with SRS. We are having, by definition, by the what we used to do in Egypt, the neurosurgeon is sitting, the oncologist is sitting. We have the neuroradiologist there for like 10 years, then we are trained enough to do it ourselves. But let me explain a little word about the Meckel's cave and the trigeminal nerve. Treating a benign trigeminal neuralgia is sometimes changing the quality of life of a patient dramatically. Yeah. We are having ladies and gentlemen who are in a very good social class. They are not sleeping, they are not eating, they are having. So to identify the trigeminal nerve and to give it a very high dose, we are up to what we call it 60 gray in one session in a very point dose, like it's a point dose, maybe for a 1 hour treatment, and it's changing the life of the patient dramatically. So identifying the skull-based lesions, the small vestibular schwannomas, it's now to be treated easily, it's larger later. Many of the neurosurgeons, many of the oncologists even are calling the patient to wait and see for a longer time. It's a benign tumor, it will grow very slowly, but it's eventually growing, compressing the brainstem, causing the loss of hearing, causing the tinnitus, which is not going even after SRS. So identifying them as an object or treatment target and knowing their anatomy is crucial for anyone who is looking forward to be a neurosurgeon and SRS expert in this position. So thank you, I'm enjoying it myself. Thank you, sir.
Okay. Okay, folks, so we have a choice now here. So if you have computers and you want to try and log into Educase, then we can have a go at doing the contouring. I think one person did some contouring and submitted those already. Professor Evram's here waiting to assist if need be. So if there's enough that you want to try and do that, we can do that for 30 minutes. If not, I brought a backup talk just in case to think about connections in the brain as well. So what would people like to do?
Start it right now and start putting the passwords to start delineating cases, please. If somebody is having computer, like 2 persons near him to get the benefit. If everyone is having his own, just start right now, please.
Okay, folks. I hope that was fun. It's quite cool that you could do that on Eduro and send the data back. We've not really used much of the functionality, but being able to contour a real case of mine on your own computer, that's pretty cool to be able to do that. So what I'll do is, because a few people wanted to discuss some connectomics for brain work, I'm going to quickly go through these 2 cases and then very, very quickly just show you some slides from the other talk where I talk about connectomics, because it's a real interest of mine. So, okay, so you had a look, basically, this is a young breast cancer patient with multiple brain metastases. She's fit, so the type of patient that we want to offer radiosurgery for. The first lesion that we saw, basically GTV1, I think everyone did a fantastic job of outlining that. And what we spoke about effectively was making a decision one way or the other as to whether you think it's involving the dura and to put the dura in or not. I think the consensus was with the radiologist, this did involve the dura. And so we included that the adjacent dura in the target. But the reason for picking this case is it's so close to the sagittal sinus, and the sagittal sinus is just dura. It's just 3 dural surfaces, basically. And so it's very important because one of our trainees started to extend out towards the dural surface onto the sagittal sinus. And so we thought, no, that's probably not right, not what's indicated here. So then the second lesion, again, a frontal lesion, fairly easy to see. Question is as to whether it was durally based. I think, again, in this case, we felt this probably wasn't durally based. And it shows the perfect example of a lesion that is a bit more complex in shape, some solid areas and cystic areas. But amongst all of the cases that I saw, it was outlined very, very well. So I think, you know, when you have really good imaging, it becomes quite easy to see the foreground and the background. Now, I teased you a bit. So some of you contoured a GTB3, this little lesion that sort of sits basically adjacent to the internal capsule, all right? Now, what I've done is I've been naughty because I've not given you all of the other imaging, but this lesion is in fact just a hemorrhage, a small hemorrhage that's gone slightly cystic, and the neuroradiologist spotted it and told us before we gave the radiosurgery treatment, okay? But the only way to know that is to look at all of the imaging before you sit down in the radiosurgery system, okay? So it's a good tip, whenever you're contouring, go to your diagnostic screen and look at all of the imaging first and check that you're happy with whatever you've got there. So, okay. And then case 2. So this is a patient with a left vestibular schwannoma. And I think what's relevant here in the history is that the patient was still able to hear in the left ear, but speech discrimination was starting to deteriorate. So we're trying to deliver 12 gray to this vestibular schwannoma. And basically what you can see when you contour a vestibular schwannoma is to think about doing it in 2 parts, okay? The first is the extrameatal part of the lesion. So this is the part that sits in the cerebellopontine angle. That is the part that's going to cause the balance disturbance, okay? And make sure that you can contour around that adequately. And you can see in this case that there's quite a bit of space between the GTV and the brainstem. So we're trying to keep the brainstem surface dose down to 12 gray. It's one of the reasons that we prescribe our prescription dose is 12 gray. We're trying to keep that dose down basically to the surface of the brainstem. And then the intracanalicular section, it starts to extend down the internal auditory meatus to here, but there is normal nerve beyond it, okay? And then the cochlea, I helped a few of you. It's much easier to see on the CT by switching to bone windows. Oops. So here you can see very clearly the cochlea on bone windows here. And you look basically for the end of the internal auditory meatus, and then you look just anterior to that space, and the greater curve of the cochlea will be just sat at that there, basically in front of you. And again, this is quite a nice case because there is space between the GTV and the cochlea as well. So it's quite nice for the physicist to produce a plan to try and keep the dose off the cochlea and to try and keep the dose off the brainstem. In this case, the priority was given to the brainstem because the patient was already losing some hearing. And with all of these things, you can't have everything. You can't have perfect coverage and low brainstem dose and low cochlear dose. So you're often asked to make some kind of compromise to decide. Nope. And then the trigeminal nerve, I really apologize. On this particular case, it was very, very difficult to see on the standard imaging. And of course, you can't see it on CT very well. So I helped a couple of you find the trigeminal nerve. But basically, when you do it, you want to have some kind of T2 weighted image or stir sequence, lava flex, any of these optimized sequences, so that the CSF fluid is bright and you can see all of the cranial nerves in outline. That's really what you're looking for effectively. So, okay. So I hope that was fun. What I thought I would do just with the last few minutes is to just talk, a few people asked about sort of connections in the brain when thinking about glioma and thinking about CTV and margins. So I just wanted to show very quickly, if I could just switch to the other slide deck. Okay. Just to very briefly, this is how I think about glioma and the CTV spread. My own research was basically in this technique called diffusion tensor imaging, which is a way of basically mapping white matter connections within the brain. And I was interested in looking at diffusion tensor imaging and to see how it was disrupted by glioma, because we know that gliomas tend to grow along these white matter pathways. So I'll just be very, very quick with this. But just remember that in the brain, okay, you normally have 3 different types of fiber that connect different parts of the brain, okay? The association fibers are the shortest ones, and these basically connect areas of gray matter within the same lobe. So they're short fibers, sometimes called U fibers, as they go from one gyrus to another within the same lobe, okay? The commissural fibers, these are important ones that connect the 2 hemispheres together, okay? And that's mainly the corpus callosum that you would know about. And then the projection fibers are things that go out beyond the cortex. I won't go through all of this, but fundamentally, when you're thinking about applying CTV margins for glioma, it's important to think about these mechanisms of spread when you constrain your CTV. So you would use, for example, a 2 centimeter CTV margin, but then having applied it in all directions, you might think intelligently about how it actually relates to that specific glioma. So as I said, the corpus callosum, this major structure that connects the 2 hemispheres, and this, somebody was asking, when would you treat a glioma without any biopsy? So this is the type of absolutely classic butterfly glioma that I would be prepared to treat palliatively without a biopsy. Why? Because the appearance is so characteristic radiologically. There's not really anything else that can do it, and it's spread through the corpus callosum from one side of the brain to the other side of the brain. Okay. Another really important pathway to think about is the superior longitudinal fasciculus. Okay, this is this set of fibers that travel from the front of the brain to the back of the brain. And you can see in this patient, the patient's got some glioma here. And can you see these little nodules of disease that are spreading? But notice they're not spreading in all the same directions. They're spreading in this pathway because they're following that pathway, the superior longitudinal fasciculus, all right? And then equally, the inferior longitudinal fasciculus is a pathway that connects the temporal lobe back to the occipital lobes in the brain. So if you see it, this is another example I found for one of my patients where you've got a temporal lobe tumor and you can see it starting to spread backwards. There's another bit of disease here, and it's basically spreading along this inferior longitudinal fasciculus, and one would predict that it would next go to the occipital lobe next, basically. So when you think about constraining your CTV, if you think about where these pathways are, okay, you don't need to have the diffusion tensor image for each patient because these pathways are so highly conserved, but it often gives you a good idea and say, okay, well, this is where I need to be careful. So where are the tricky ones? Oh, come on. This is the tricky one, okay? This is the uncinate fasciculus, and it's an old connection that goes through the limbic system that connects the temporal lobe to the frontal lobe, all right? But I don't think in my practice I've ever actually seen a temporal lobe glioma spread to the frontal lobe through the uncinate fasciculus. So how important it is when you're dealing with a temporal lobe tumor to edit or include the frontal lobe that sits adjacent to it is not clear. I generally don't edit my CTV off that region just in case, just to allow for that mode of spread. Okay. And then just to show, sometimes we learn a lot about connections, a lot about normal physiology from the abnormal. So this is a patient that doesn't have a corpus callosum at all. You can look at those big baggy ventricles. You see that? You might think the patient's got hydrocephalus. Who, be honest, who first, when you saw that, thought, well, maybe the patient's got hydrocephalus? Good, so did I. The problem is basically is that without the corpus callosum to hold and tether the ventricles in the right place, the ventricles end up in this big baggy shape, but it's not actually hydrocephalus. So I had treated a patient with this, they had no corpus callosum. What was interesting was that the patient, apart from severe reading difficulty, he was absolutely fine. Yeah, the fact that his left and right side of the brain weren't connected, and clearly they were using other smaller commissural fibers to connect together. The ladies may say that most men, the left side and the right side of the brain aren't connected, so that's probably fair enough. And then, of course, the final thing, which act as very rigid barriers to tumor migration, are the falx and the TENT. Okay, so there is no reason that you need to extend for a glioma the CTV across either the falcine surface or the tentorial surface, and you can edit basically to there, very freely. Okay. Anyway, so I think that's all I wanted to say really just on that particular subject. So I hope that was interesting. I hope it was fun. I think the key thing I hope that you would learn from today, my takeaway messages would be hug the imaging, okay? Just like you want to know as much as possible about the patient before you take responsibility, look at the diagnostic imaging first, because otherwise one day in your life, you will make a mistake. You'll open the case in the radiotherapy system and you will contour something that enhances, and it's not tumor, okay? So if you remember one thing, that's the one thing that Raj wants you to remember, basically, okay? And then the second thing, if you can remember two things, is that the principle of radiosurgery and coverage is different to the principle that we use for standard fractionated LINAC-based radiosurgery, okay? We're delivering a huge dose to destroy the tumor's blood vessels with radiosurgery. We do not need to necessarily think about covering all of the areas where that tumor might have spread. We should use the best imaging to tell us as best as possible where the tumor might have spread, okay? So if possible, try and, if you get one of these things in your center, try and encourage them. If they're saying they want to put a PTV margin on, tell them, say, I don't want to use a PTV, please. And if it's all possible. So I'll stop at that point. I'm happy to answer any questions. Thank you.
before asking the floors for question, I would like to thank you myself for bringing this kind of expertise to our medical society, our colleagues from different universities in Egypt and from Arab and African countries. Again, we have a mindset to change about the difference between radiosurgery and radiotherapy, and a lot to build upon what you have started today. I hope you have a little bit of time to see around Cairo today before traveling. Thanks to the ESTRO for a long time collaboration with Ain Shams University. Thank you so much, sir. Thank you. Any questions from the floor, please? Thank you. Thank you.
And those of you who have checked your contour, you can come and work in my department anytime.